to you all. Thank you very much for your continued interest in our program, which is growing. It's been going a few years now. We're very fortunate to have back for the third occasion Dr. Lena Kimona, who is a trainee in neuropathology at Cambridge University Hospital, that's Addenbrooke's Hospital in the south of England. Lena has talked previously about traumatic brain injury, about brain tumours. She also does a lot of autopsy work, and this is an area really in the UK. I think pathologists get generally de-skilled in neuropathology because it's a very specialist area in the UK. I know for many other places in the world, it is part of people's general workload, and so it's really important to be able to have expert opinion. So very grateful again to Lena for her third occasion supporting this program. Also thank you to Diagnexia for support of the webinar program and for advertising it. So without further ado, Lena, I will pass over to you so that you have as much time as possible. Thank you very much.
Thank you. So this is a very complex subject in neuropathology, and I'm going to do my best to basically focus on what you can see on H&E, silver stains, and also a macroscopic examination of the brain. If you look at a textbook, you'll find a lot of information about immunohistochemistry. I'm going to touch a little bit about that, but I am aware that the places where you're working, you may or may not have as much immune as we have in here in our brain bank. So first of all, I want to talk a little bit about the foundation of the concepts of neurodegeneration. This is a progressive dysfunction and loss of neurons. And it's very important. I'm going to repeat a lot of things a lot because I really want to prove a point that clinically they are not unique. So you can have several diseases that the neurologist diagnoses as one thing, but molecularly they're very different etiologies. And if you think about neurodegeneration, think of three things. Think about the protein, the clinical features, and where the pathology is located. Not just in the microscopic level, whether it's inside the cell, but also which cell it's inside, and also where in the brain the pathology is located. So here I'm going to show you a schematic that kind of shows the central theme across many neurodegenerative diseases. First of all, we have different proteins that are strongly associated with different pathogenic processes. So we have amyloid beta, tau, prion, alpha-synuclein, and TDP-43. Those are the main ones. Now, each of these is linked to a different condition. So amyloid beta, you will think of, and tau together, you'll think of Alzheimer's disease. Prion protein, prion diseases like mad cow disease, of Creutzfeldt-Jakob disease. Alpha-synuclein, we see it in Parkinson's and Lewy body disease, and TDP-43 with ALS and frontotemporal degeneration. Now, again, clinically, they could look different, but they have one thing that joins them all together, and that is that they can misfold. So if you think of the process of what happens at the protein level, they are usually folded into these very precise three-dimensional structures, and that allows them to function correctly. But as we age, or if you have genetic mutations, or if the protein cannot be clear, if there's any oxidative stress or any cellular injury, the proteins can adopt an abnormal conformation. So this is what happens. Initially, the proteins will form a monomer, and this is just a single abnormal protein molecule. Now, at this point, this change may be reversible, and the change may be very subtle, so you probably will not see anything. But what happens is they start to stick together and they start to form these oligomers. At this point, we know that this protein conformation is already toxic to the neurons and everything around it. Now, these oligomers can start to interfere with the synaptic signaling and the integrity of the membrane, the function of the mitochondria, and even the transport between the cells. So at this point, you're already seeing some neurological dysfunction before we see anything histologically. So at this point, we may not see anything on our slides. But what happens then is they start to form these protofibrils, and eventually they start to form these fibrils. Now, these are very organized, as you can see, sheets, structures that are quite insoluble, and the body cannot degrade this. So they start to accumulate. And then you start seeing these plaques or inclusions that we actually see on examination of our histology slides. So for example, in amyloid, it will form these plaques and it will form neurofibrillary tangles in Alzheimer's disease. In Parkinson's disease, the protein is going to form Lewy bodies with alpha-synuclein. And then you'll see this abnormal TDP-43 in frontotemporal degeneration. Now, it's important to remember that these inclusions are the end result of a much longer pathogenic cascade. So by the time you see them microscopically, this disease process has been happening for years, maybe even decades. Now, there's another concept that's important that we all understand, and that is that they can behave like a prion-like manner. And what I mean by that is that if you have a prion, like in prion disease, the issue with that is that if it touches, this is how I understand it, if one protein is next to the other one, it's going to also induce changes in that other protein. So they act like a template that induces normal proteins that are next to it to misfold. And that allows for the pathology to spread through neural networks. So as I'm explaining later, the different pathologies, I'm going to show you how the different diseases spread in different parts, depending on how they're connected. And so this explains the progression patterns that we see in many of these diseases. Now, even though they're clinically and anatomically different, there is one unifying biological principle, and that is that these proteins are misfolding, they're aggregating, the body can't clear them, and they start to accumulate, and this drives different diseases. Now, the second concept that's quite important is the clinical classification. There are many ways of dividing these conditions. We can divide them between cognitive predominant and movement predominant. But this is doesn't mean that someone with Alzheimer's disease may not have movement predominant movement disorder. Same as with Parkinson's disease, they may have some sort of cognitive deficit. So this is a very simple way of dividing them, but this is not rigid by any sense of the meaning. And then going back to these misfolded proteins and what I was talking about location. So we have the different proteins here, and then you can see how these proteins can be either extracellular or intracellular. So amyloid beta, I want you to associate this with extracellular, and tau intracellular, but it can be located both in the neuron and also in the astrocytic and oligodendroglial cells. Then prion disease would be extracellular. Alpha-synuclein can be in the neuron, also in the oligodendrocytes. And the other thing to remember is that the morphology of the inclusions will change depending on where they are and which pathology we're talking about. And I told you I was going to repeat a lot of things. So this is another nice schematic that shows us how this clinical and pathological correlation is so important. So first we have here, if we look down here, we have all of the syndromes. So this is what the clinician will give us as a diagnosis. So they may have more behavioral symptoms. They may have non-fluent pathology, or they may present with more frontal symptoms, for example. But as you can see, there's an overlap between what pathology is driving this. And this schematic is quite nice because it shows you which proteins you can expect to be extracellular. So you have prion and amyloid beta, and which ones are intracellular. And it also gives you information of the genes. So the genetic part is important. For example, if we're thinking of Alzheimer's disease, there are some abnormalities specifically in APP and PSEN1 and 2 that are related with a younger onset of Alzheimer's disease. And in TDP-43, we have very specific abnormalities that will give us a very specific pathological finding. The other important thing here is you have the normal proteins and then what accumulates. So here, for example, we have the tau, and is going to be accumulated as hyperphosphorylated tau. And don't worry if none of this is kind of making sense yet, because I'm going to talk about this again in a bit. And again, third time I'm going to repeat this, but this is very important. We have the clinical diagnosis, which can be quite different to the pathological. diagnosis. And I'm going to focus initially a lot on the macroscopic changes that you can see even when you're doing the postmortem or as soon as you receive the brain, because the brain can give you information of, depending on where the abnormality is, you can already have an idea of which pathology you're dealing with. So here you can see the normal brain, the meninges have been removed in both cases, and you can see, I mean, this may look atrophic to some of you, but this is entirely normal. When you compare with the Alzheimer's disease brain, you can see that the gyra are much more thinned. And in general, if you can stick your finger between the gyra, that is atrophic. And you can see there is global atrophy on this brain on the right. Now, let's walk through the key anatomical patterns of atrophy, because this is the first diagnostic tool and it costs nothing in terms of lab time. It's just your time looking at the brain and getting already an idea of what pathology you could be dealing with. So we're going to talk about Alzheimer's disease first. I'm only going to focus on the macroscopic findings for now, and then I'm going to show you the microscopic changes. So as I mentioned, in Alzheimer's disease, you have amyloid and tau pathology in form of neurofibrillary tangles. And in Alzheimer's disease, the biggest atrophy is going to be in the medial temporal structure. So that's the hippocampus and the entorhinal cortex. You will also see atrophy in the multimodal association cortices, especially the parietal and temporal. And when you open the brain, you're going to see the hippocampus looks very small and shrunken. But if also you have parietal cortical thinning, then you need to think of Alzheimer's. So what happens here is the atrophy is going to start in the hippocampus, which is not represented here, but it's going to be around this area, and the entorhinal cortex. And then this is going to cause the initial short-term memory loss. And then it's going to start spreading, and it's going to start going to the parietal, lateral temporal lobes, where the patient is going to develop language and spatial deficits. And so you can see as the disease progresses, the severity of these areas gets more. And you can see the hippocampus in this stage 5 and 6 is in red, because it's the most severe part of the disease. Now, there is a separate condition, which is Alzheimer's, but it affects the posterior part of the brain. This is called Benson syndrome, and it's a visual variant of Alzheimer's where the atrophy targets more the parietal and occipital, so the posterior part of the brain. And this gives a visuospatial dysfunction, and the patient has difficulty in reading or processing complex objects. But I'm not going to focus on that. I'm going to focus on the Alzheimer's diseases in general later. Now, this is a brain with severe atrophy of the frontal and temporal lobe. So if you remember your anatomy, or if we look at this image here, you can see that the frontal lobe is the largest part of the brain. And what we have here is a really, really shrunken frontal and temporal lobe in here. You can see how the occipital lobes looks much bigger. And when you do the coronal section, what you can see here, you can see the temporal lobes are really, really shrunken. The gyra really thin. And the hippocampus is, I mean, it's like really small. So all of this is really, really small. And what happens to this patient, if you remember, frontal lobe is going to give you behavioral changes. They may have language problems, but they will have intact memory, at least initially. And they're often diagnosed as a psychiatric disorder, or misdiagnosed as a psychiatric disorder. So within frontotemporal dementia, there are specific patterns that will help you figure out which variant the patient has. So for example, if you have frontal lobe and anterior cingulate atrophy, and the patient presents with severe personality and behavioral changes, that's more a behavioral variant, and the neurologist will tell you this. If they present more with semantic dementia, then we expect more anterior temporal pole atrophy with loss of word meaning and object recognition. And then if they have more perisylvian atrophy, that's going to be more progressive non-fluent aphasia. So they're going to have very difficult halting speech. So it's important that you remember that the location and asymmetry of atrophy will help you guide the sampling strategy before you've done even a single block. Now, in terms of the basal ganglia and the deep brain structures, I'm talking about the caudate, the putamen, the globus pallidus, subthalamic nucleus, and substantia nigra. In these cases, you may see more preserved cortex compared to more advanced disease. So in here, we have an example of Huntington's disease. I'm not going to talk about the microscopy of this condition in the interest of time, but I do want to show you how this looks macroscopically. So we have the caudate nucleus, we have the putamen here, and the globus pallidus here. And as you can see, the caudate is meant to kind of feel the lateral ventricles. But in this case of Huntington's disease, you can see that this is completely flattened. And this is what's called a boxcar ventricular appearance. So as you can see, it's not bulging. It looks completely flat. And you can also see that the putamen is atrophic. It's not the best picture, but you can see that this is much smaller than, it's not bulging as much. Now, in the right clinical context, if you have a family history, you have someone who has coriform movements, you can be very confident of the diagnosis just looking at the macroscopic image alone. Parkinson's disease, again, we learned from medical school that the key gross finding is the pigmentation of the substantia nigra. Normally, you will have this very dark pigment. This is the neuromelanin in the dopaminergic neurons. And as the neurons die, this pigment is lost, and you may get this kind of brown discoloration. Again, visible on the naked eye is your first diagnostic clue. However, this is also seen in other conditions, which I'm going to mention later. But if you have, again, good clinical history and you have this, then you'll have a good chance of figuring out which condition this patient had. If you have atrophy in the putamen, so we have putamen here, and it looks small, shrunken, and more importantly, with this kind of gray discoloration or full of lipofuscin. But also you have cerebellar atrophy, and also you have the peduncles are very small. Then you can think of multiple system atrophy. Again, I'm going to talk about this later in more detail. Now, very broadly, we're going to talk about cerebellum and brainstem. If we think of which condition we're looking at cerebellum, I'll just talk about MSA. And this is what you would see in spinocerebellar ataxias. So here we have a normal cerebellum, and we're going to ignore this midbrain for now, but we're just going to focus on the cerebellum. And you can see how the folia is nice, filling the space, whereas in the case of spinocerebellar ataxia, you can see how there's atrophy, and you could imagine you'll be able to put, I don't know, a piece of paper in between this folia. And what we can see here is atrophy of the midbrain. So initially, this would originally this would have been much bulkier. And we talk about the hummingbird or penguin sign, and I'm going to show you an MRI image later. But the first clue here is that this is really thinned. We also can see atrophy of the subthalamic nucleus, which is this bit here. You can see that there's discolored. Now, I am aware that this can be a little bit tricky to identify when you're doing a brain cut. But if you see this discoloration, it's kind of a clue that you're dealing with progressive supranuclear palsy, or PSP. The other thing is the atrophy of the cerebellar peduncle, and you may see also pallor of the substantia nigra. And then corticobasal degeneration. The most important finding here is that you're going to see atrophy of the superior frontal gyrus. So if you follow the Sylvian fissure, you will find it. So this is where the greatest pathology is present, but also you can see atrophy of the corpus callosum. You'll also find there is ventriculomegaly, and the cerebellar peduncle will be more preserved. There will be some pallor of substantia nigra, and then you're going to see, if you look at the cerebellum, the dentate nucleus is going to look blurred. Again, I'll go through all of this again. And then in cases where you have more multifocal or diffuse involvement, You can have cortical atrophy in Lewy body dementia. It can be much more subtle. So this would be a diagnosis that you would do on microscopy. As you can see, this, there's a little bit of atrophy, but it doesn't look too bad. And that's also the case with prion disease, which I'm sure you're aware. It's important when you're doing a case of prion disease, or ideally you wouldn't do it unless you have a specific preparation. I'm not going to talk about prion disease today, but we can definitely do that in a future talk. Now we're going to talk about the microscopic findings. And I'm really focusing, as I said, on the H&E. I'm going to talk about silver stains and then a little bit about immunohistochemistry. So the first thing, and as I talked about it initially about the diagnosis or the conditions to diagnose a neurodegenerative disease, you need to have neuronal loss. And when a neuron dies, you're going to have activation of the astrocytes and the microglia inevitably. And what that's going to cause is you're going to have this spongiosis, importantly in the superficial cortical layers, and you may have spongiform change when you look at the slide. If the neurons are affected, then you're going to have swelling of the cytoplasm. The nucleus is going to move to the side, and you may see axonal swellings on H&E. And then again, identify if the protein deposit is inside the cell or outside the cell. Very important that there is no inflammatory, neoplastic cell infiltration, or any infective agents that can cause this nerve damage. And also that you don't have any evidence of toxic agents that are causing the nerve damage. So that's where your history is quite important. And before we go through individual diseases, I want to talk about sampling. Because if you have a resource limited setting where you can only take a few cassettes, you need to choose the right regions to sample. And so for each one of the conditions I'm going to talk about in a second, I'm going to show you one slide that shows you the key areas to sample, guided by the clinical history and your macroscopic findings. And you're going to start seeing, you will see a pattern of a few blocks that we recommend that you always take because it will give you the highest diagnostic yield. So important to take a frontal lobe. Here they sample it there. We normally sample the watershed area. That's because it gives us information about watershed infarcts, but also you get a little bit of meninges, so you can rule out meningitis or any other things that you may not see macroscopically, like this is a viral meningitis, for example. We also want to sample the frontal cortex because it helps us with staging of some of the diseases. Always sample the hippocampus, and we tend to go we here in the brain bag we sample anterior and posterior hippocampus, but if you're limited, I would advise you to look for the lateral geniculate nucleus, which looks like a Napoleon's hat, and then take that sample of the hippocampus. And if at all possible, try and include not just the entorhinal cortex, but also include some of the temporal lobe. In some cases, the atrophy is such that you can include almost all of this in one block. So if that's the case for you, then just include all of it, because then you can do a lot of staging just with one block. The other thing is to sample, it's not shown here, but you want to sample the midbrain at a minimum. You want to look at the substantia nigra. And then if you can take more blocks below the midbrain, then take some pons and take some medulla, which will help you. But at a minimum, a frontal lobe, a hippocampus with temporal cortex, and then your midbrain. So we'll start with Alzheimer's disease, as I'm sure you know is the most common neurodegenerative disease. Patients will present with an amnestic syndrome. Worldwide, as I was saying, about 60 to 70% of cases have this. And some of these rarer or less common variants include the one I mentioned with the posterior cortical atrophy. And then there's also a frontal variant, Alzheimer's disease, where they have more frontal symptoms. If they have early onset, less than 65 years old, that's about 5 to 10% of all cases, then we're thinking of a genetic cause and the genes that I mentioned earlier, PSEN1, 2, or APP. And finally, macroscopically, as I mentioned, you're going to have cortical atrophy. It's going to show widened sulci and is going to be more in the medial temporal structures, parietal temporal association cortices. And usually there is relative sparing of the occipital cortex and primary motor cortex until later in the disease. And then microscopic, we're going to have a look at that, but remember amyloid beta and tau pathology. So this is an important slide because it explains how the disease progresses at the protein level. So initially what you have are these amyloid beta plaques or diffuse plaques. And what you have is these amyloid beta peptides, which are cleaved to form from the amyloid precursor protein. Now, initially, these deposits are very diffuse and loosely organized. And remember, this is extracellular. At this point, they're not very toxic and they're not very dense. So the neurons around may look intact. What happens later is that this plaque starts to mature and you start to form a more dense core. So these bits of protein start to arrange themselves into these fibrils, like I showed you at the beginning, and this starts to become more insoluble. Eventually, this forms this dense core amyloid plaque. Now, this dense core is surrounded by a halo of less compact amyloid and degenerating neural processes. And what happens is you start to get more amyloid beta accumulation, then you get the microglia and astrocytic response, and then you start to get cross-linking of the proteins and oxidation, and this is going to stabilize this core that you have in the middle. So what happens then is that once you've established this core, the neurons start to respond with injury. So the axons and dendrites near the plaque start to become swollen, distorted, fragmented, and you start to get this kind of neuritic plaques or dystrophic neurites. They start to accumulate in organelles and vesicles, and misfolded proteins are just accumulating everywhere. And finally, you start to get this tau accumulation because the tau protein starts to become abnormally modified. Now, normally what tau does, it stabilizes the microtubules in the axons, but when it's diseased, tau becomes hyperphosphorylated, like I showed you earlier. And what happens is that instead of staying attached to the microtubules, it becomes detached, and those microtubules collapse, and therefore the axon cannot make the normal transport. And therefore, tau begins to misfold and aggregate. And it forms these aggregates that you can see forming pre-tangles, eventually forming a tangle. And then you have this kind of flame shape, very typical appearance on this pathology. And just to bring the point again, I want to focus on this. You have the amyloid beta accumulating in diffuse deposits, then it fibrillates and forms these dense cores. Then the nearby neurites, these red bits, degenerate, and you have these dystrophic neurites. Then tau becomes hyperphosphorylated, and then you get this neuritic damage due to tau accumulation and amyloid accumulation. And this is what you would see on the H&E, and the arrow here is showing you the microglia trying to help clear out this. So on microscopy, what we would see is neurofibrillary tangles or NFTs, and we would see them in the hippocampus, the cerebral cortex as it progresses, and the hypothalamus. You may see the senile plaques, which help with the Serrat staging. Don't worry about the staging, I'm going to explain it in a second. And what you'll see is two components, the beta amyloid and the neurites, which are the swollen axons, as I explained just now. And this is more specific for Alzheimer's than the NFTs. And what we're staging is this the load of the senile plaques. The other thing, again, common to all ND diseases, is neuron loss. And important to remember that you may also see as amyloid angiopathy. So on H&E, this is what you may see. We have NFTs, which is neurofibrillary tangles. You can see them on H&E. I'm going to show you lots of examples. And then we can also see this granulovacuolar degeneration here. So these little dots in there kind of with clear areas. This is a nicer image from the Kovac book. And you can see these little dark dots surrounded by pale. This will be the tau stain, so you can see the neurofibrillary tangles. And the amyloid plaque, remember, extracellular. This is another example, and this is another example where you can see the microglia, which look kind of comma-shaped, and they're really, really small. And then they're just, again, around this amyloid beat. And then here you have the amyloid beta staining. You can also see tau dystrophic neuritic plaques on H&E, much harder to appreciate than if you have immunohistochemistry, like you can see at the bottom. But you can kind of see that this area is disorganized, and you can see the microglia kind of around it. The other thing you can see are hieranobodies. So these are bright eosinophilic rod-like structures that are adjacent to the neuron. This is a very non-specific finding, but it's characteristic to find in the CA1 region of the hippocampus. It also helps you to know that you're in the right place. And last but not least, and these are not specific for Alzheimer's disease. They're just, supportive of the condition. And here are a lot of examples of neurofibrillary tangles. You can kind of see that, imagine that this would be the misfolded proteins there. It has this kind of fibrillary appearance. And very important to look at this O image here, because in here you cannot see a neuron per se. You cannot see a nucleus. But what's happened here is we have a ghost tangle. So that cell is dead, is gone, and all we have left is the tangle left behind. And here we have really nice stain with silver stain. So this is a Bielchowski that shows the tangles, and it can also show plaques. There are euphilic, and you will see the neuritic corona. I think I have an image later. So even if you don't have immunohistochemistry, if you have a good silver stain and you stain the hippocampus and the temporal cortex, that is going to give you enough confidence that you're dealing with AD. This is immunohistochemistry staining. So this is a nice image of a neurofibrillary tangle. The asterisk is the nucleus, and again, it has that flame-shaped appearance. This is a pre-tangle, so you can see it's not as dense, but it is staining. This is a more established one. And then what we have here, it's again another ghost tangle, and what we have here is a neurites. So what happens here, again, remember I mentioned that you can have this aggregation in the axon of the neuron, and that's what you're seeing here. And they're basically trying to show you that you have some little spines in there. I mean, I wouldn't blame you if you don't believe me that there are the little spines there, but we wouldn't look at it at this power. We would look at them like this, and they look like little threads just in the background. So this is where it gets a bit more complicated, because we're going to be talking about the staging. And our gold standard is to use the ABC system. So A is for the amyloid phase or the thal phase. B looks at the neurofibrillary tangles, which is tau, and C with CERAD is going to be the neuritic plaques. Important, they need to have it remembered this way. So A, amyloid, B is tau, and C is going to be amyloid with tau neurites. If you don't have the tau neurites, then you cannot use it for C. This will make sense in a second. So what we have here is A. This is the progression of the disease in the amyloid stage. You have initial accumulation of amyloid beta in the preclinical stage, kind of phase 1 and 2. And as it progresses, it starts to get darker. So towards the end, you're going to have a lot of cortical deposition compared to the other areas. In phases 2 and 3, you start to see more accumulation in the midbrain, you can see here. And then eventually you can have also accumulation in the cerebellum and brainstem. Now the NFT staging, which is BRAC. This is a really nice image of how it progresses. So we start with entorhinal cortex. And at this point, the patient's either asymptomatic or very subtle memory changes. That includes 1 and 2. So you can see the hippocampus there and then the entorhinal region. In stage 3, and 4, you start seeing extension to the hippocampus and limbic system. So in here, the patient is going to have mild cognitive impairment and early dementia. And then in stage 5 and 6, you're going to see that the whole cortex is involved. So going back to the sampling, if you only have a hippocampus and then a cortical sample, and you have this NFTs here and here, then you already know that you're in stage 6 and you're, home and dry. So you're good to go. And then C, the CERAD scoring, we're looking at plaque density. So remember, you need to have the tau and the amyloid. So in here, we don't have neuritic plaque, so that would be a C0. And then C3, you look at the density per 1 square millimeter, so like by 40. And then you just basically by eye, you decide how frequent the plaques are. And then at the end, you take your ABC score and you can give you the likelihood that the pathological changes explain the dementia the patient had in life. So if it's, for example, a high ABC score in someone that's 80-year-old, and you could say, okay, this is pure Alzheimer's disease. But if it's a low score in someone who had dementia, then you need to look for an additional pathology. And this is where the concept of co-pathologies appears, because you can have a main pathology that's not causing a lot, but you can have a co-pathology that is causing the symptoms in the patient. And the way you do this is you take your amyloid score, your A, so 0 to 3, then the plaque density, and then you look at the, so, you know, let's say we're here 1 and 2 or 3, and then we look at the NFT, and let's say that this low, then that would be low probability of the dementia being explained by Alzheimer's disease. So this is the key slide, and I'm going to do that for each condition. So key regions to sample, as I said, hippocampus, have some frontal cortex, and that should be theoretically enough. You're looking for neurofibrillary tangles, granulovacular degeneration, here are no bodies, and loss of this neurons in the hippocampus. Optionally, you can do silver stain. So we have Bichalski, which is this one. You can see the plaques and the tangles. Gallias, again, to show tangles, and Congo red for amyloid. And as a simplified staging, if it's only interrenal, then you're approximately 1 or 2. If the hippocampus is involved, you're already in 3. And if the neocortex is involved, then 5 or 6. Synucleopathies, we have 2 basically. So we have Lewy body disease, which includes Parkinson's with dementia, and dementia with Lewy bodies, and multiple system atrophy, of which there are 2 types. I'll talk about them in a second. So Parkinson's disease is the second most common. There is a genetic susceptibility, and there are also monogenic causes. These patients usually have a triad of tremor, rigidity, and bradykinesia, but the pathology usually begins way longer before they have any motor symptoms in the brainstem and autonomic nervous system. This is one easy, again, the pigmentation of the substantia nigra. And if you can, look at the locus coeruleus, and you may see atrophy of the frontal temporal lobe. So you can already see a difference with Alzheimer's disease. And this is what you would see with alpha-synuclein pathology. So the first one, Lewy bodies. I have immunohistochemistry image here, but your H&E is your help, and I'll show you where to find the Lewy bodies. And they are inside the neuron, not in the nucleus, they're just adjacent, and they have this very typical spherical inclusion shape. You also have the Lewy neurites, which are on the axon, so they have like this corkscrew elongated shape. And in multiple system atrophy, they are more in the there is cytoplasmic inclusions. You can also have nuclear inclusions, as you can see in here. But for now, we're going to focus on the Parkinson's disease part. So we're looking for Lewy bodies, round, eosinophilic, intracytoplasmic, and they're going to have a pale halo. You should look for extraneuronal melanin and macrophages, because basically if you have a pigmented neuron that dies, you will have macrophages trying to clear that area, but also you will have all the melanin that doesn't get gobbled up is going to be sitting there, and that's a clue that the neurons are dying. You may see Lewy neurites, and you may see pale bodies, which are not quite Lewy bodies, but they look like Lewy bodies, just without the halo. And then if we do silver stains, we will see the Lewy neurites, and then if you don't have immunohistochemistry and you have Lewy bodies in the substantia nigra and the pigmentation, then you're done. For dementia with Lewy bodies, then you need to see them in the cortex. So with that cortical block that you have, then that's a good way to start. So this is what I mean about extracellular pigment. You can see your pigmented neurons here, and you can see that this is kind of floating around with some glial cells around. This one's maybe a better example because there's nothing around. So this pigment is just floating there. This is a good example of Lewy body. So you have your pigmented neurons, and you can see the round Lewy body. This is a pale body, so you can see it doesn't have that kind of round, like targetoid appearance. And I'm showing you Marinesco body because it's a good differential. It's something that happens with aging. First clue that this is not a Lewy body is that you don't have the halo. It's not a pale body because it's very dark. And also it's inside the nucleus, and we're looking for cytoplasmic. So this is neither of those. You can find fewer of these in Parkinson's disease, but remember, if you see this, don't be confused. Just remember they are age-related, incidental, and intranuclear. And this is a good slide to show you the difference between a normal person. So there's 80-year-old, and then we have a person with dementia with Lewy bodies. So we'll be looking at the vagus nucleus. You can see this is nicely populated by neurons. And in this person, I mean, I can't see maybe one neuron here, maybe two neurons there. This is the locus coeruleus, nicely pigmented in here. We barely see any, and we can see free pigment. It's not inside any neurons like in this one. And in the substantia nigra, this one is practically depleted. You can see it's very gliotic. So this is good enough for us to say what this is. More images of Lewy bodies. We have the pale halo, some more or less convincing than others, but you can see some of them are really, really nicely demarcated. Now, the importance here is when you're looking for these Lewy bodies, don't go into the cortex straight away. Like, make your life easy. Go first to the substantia nigra or the locus coeruleus because you have the pigmented neurons. And if there are Lewy bodies, they're going to jump at you because you will see that the pigment, it looks very dark, and then you have this pink blob. If you look at it in a pink with purple background, like in the cortex first, you might not find any. Also, it helps to keep an eye on the lesions once you've seen one. Here, the asterisk is showing you some lipofuscin. It doesn't project very well, but it has a different appearance than the pigment. The pigment is really, really dark and granular. Now here we have a combination of Lewy bodies and Marinesco. So I hope you'll be convinced that this is a Marinesco body because it's in the nucleus. Same with this. So this is staying with ubiquitin, P62, and alpha-synuclein. And yeah, it's again to show you that both ubiquitin and P62 can highlight both the neurites and also the Lewy bodies in immunohistochemistry. I might need to speed up a bit. Okay, so in Parkinson's disease, unlike Alzheimer's disease, had a different progression. So we start with the dorsal motor nucleus of the vagus. And then as it progresses, it starts to go to the substantia nigra, then to the cortex, and eventually all the way to the primary and secondary areas. So if you sample the substantia nigra and you have Lewy bodies there, we're already at stage 3. So that is like kind of minimum. You are stage 3, and then you look at your cortex. If you have them there, then you have a good idea of what you're dealing with. In case you're wondering, how do I find the nucleus of the vagus? You have your section of medulla. You have your inferior olivary nucleus, this wiggly bit here. You will look for the 10th nucleus here, and if you go down, you'll have the 12th. So you need to go a little bit higher. So for Parkinson's disease, we also have a Braak staging. So as I said, we start in the motor nucleus, stage 3 already substantia nigra, and at this point they're already symptomatic. And then if we go down, we're going to see cortex, and primary motor and sensory cortex. Again, if you sample that area regularly, then that's fairly easy. So sample the medulla, midbrain, and substantia nigra, hippocampus. You might find some co-pathology, and then frontal cortex, and look for Lewy bodies at all levels. And you can do silver stainings for this. And this is your kind of summary. Highest yield, looking at the midbrain, and then cortex or amygdala if you can. H&E is often insufficient, but ideally, if you have alpha-synuclein, that's even better. But if you don't have any of that and you have clinical Parkinsonism, pallor of the substantia nigra, neuronal loss, and some Lewy bodies, then you can say that is supportive of Parkinson's. Multiple system atrophy is also a synucleinopathy. We have 3 clinical phenotypes of Parkinsonism 1, cerebellar, and autonomic. So in the Parkinsonism, you're going to have more striatonigral degeneration. So the putamen is going to be atrophic, like I showed you earlier, and you're going to have the hemosiderin discoloration. In the cerebellar form, as it says, is more olivopontocerebellar atrophy. And in the autonomic is the rarest and hardest to diagnose morphologically. So we're going to kind of focus on these two. The defining histological lesion is the glial cytoplasmic inclusion, or GCI, also called PAP-Lantos bodies. They're argiophilic, so we can use the silver stains, and they're going to have these sickle half-moon shape inclusions in oligodendrocytes. Now, this is easier to find in white matter, but it's a very typical appearance, so it should be relatively easy to find. And important here, you have different silver stains. The gallius is going to be the most useful for MSA without immunohistochemistry. So if you see this sickle shape inclusion in oligodendrocytes, it is MSA until you can prove otherwise. And this figure is very important because it shows you how multiple system atrophy can look macroscopically normal. So we're going to start looking at the basal ganglia. We have the putamen here, and we have the globus pallidus, the little triangle. This is a case of more kind of typical. You can see the discoloration like I showed you at the beginning. But in here, the putamen looks nice and big, and it looks, pretty normal. If we look to the pons, this is a case where you can see that the height of the pontine base is much smaller compared to our case. This looks pretty normal. If we look at the inferior olive, again, in our case, looks nice and prominent, where here it looks very shrunken and maybe a little bit yellow. And if we look at the cerebellum, you can see that their white matter is pretty much preserved in our case. And here you can see that the white matter is much thin, and also you can see the blurring of the dentate nucleus. But when you look under the microscope, you can see that there are these sickle cell-shaped inclusions basically everywhere you look. And in the putamen, also on microscopy, you can see some gliosis and neuronal depletion. So this case meets all the diagnostic criteria for minimal change multiple system atrophy with the alpha-synuclein pathology, with typical GCI morphology, but macroscopically it looks entirely normal. And microscopically, you may see the astrogliosis, which is basically a busier slide, and you may be able to see inclusions. So in sampling here, you need to look at the pons, and you may see that shrinking of the pons. You may see the atrophy of the cerebellum with the degeneration of the putamen, and then the pillar, the substantia nigra. Without alpha-synuclein, is difficult to diagnose this, but you have an anatomical pattern that's going to help you. This also shows you, again, how it looks in ubiquitin P62 and alpha-synuclein, and you can see the inclusions there in all of the slides. I'm almost finished. I hope you're still with me. Talk about frontotemporal dementia. This is the third most common. And you have different variants. So you have behavioral variant, semantic dementia, progressive non-fluent, and then you have some overlaps. Now, this is a fairly complex part of this talk, so I really hope that you're still with me. But important here is that you're going to have this frontal temporal atrophy, and you may see this knife blade gyres. So it's really, really thin. And if it's more in the superior temporal gyres, then we're thinking of this TDP type C, and that will make sense in a second. So, as I said, this is an umbrella pathological category. We have 3 different types overall, and this graph can be much more complicated. If you Google it, you'll find it with many more things, but I just wanted to focus on the most common, most important. So it can either be tau pathology, TDP43 pathology, or FAST pathology. Tau pathology, we're going to talk about PICS, PSP, and CBD, and TDP, we're going to talk about A to E, the most common being C. So what we have is superficial spongiosis in the layers 1 and 2. You're going to have lots of neuron loss in the temporal cortex and the frontal cortex. And you may see these ballooned neurons. You may see PICS bodies. And here's where the silver stains are really going to help us. So what we have here is temporal lobe atrophy. You can see how nice these gyra are. And then when you make it to the temporal lobe, you can see how thin they are. You can see there's barely any white matter. It's just really, really, really thin. And you can see how the hippocampus is really tiny. And this is why we would see in immunohistochemistry on TDP-43. So you can have inclusions in the neurons in the cytoplasm. You can have them intranuclear. You can have neurites, and you can also have glial inclusions. So this is a TDP-43 showing a very low power, how thin this cortex is. I mean, a whole gyre shouldn't really fit into one side, and we have 2 or 3 in here. So it's quite atrophied. We have some gliosis here, and then on the hippocampus staining, you can see the inclusions there in the granule cell layer, and then you can see this very elongated neurites. In terms of tauopathies, we have 3R, 4R, and 3R and 4R. I'll explain what that means in a second. 3R, Pick's disease. 4R, we have these 3, and 3 and 4 is Alzheimer's disease. Sorry, I'm going a bit fast, but we're running out of time. Okay, so 3R, as I said, Pick bodies. So they are spherical, neuronal and glial. And then 4R, again, focusing on the most important, we have CVD, astrocytic plaques, and tufted astrocytes. Now, these are pathognomonic, and this can be quite difficult to differentiate when you're looking at the slides. But the easiest way to remember this is that in corticobasal degeneration, you have astrocytic plaques, and you can see in the figure here that the accumulation is at the periphery of the astrocytic process. So it's a bit more spread. Whereas in PSP, the tufted astrocytes are a bit more close to the nucleus, so it looks more compact. And if you remember that, I'll be happy. So Pick bodies, spherical, and then the plaques more spread, and the tufted closer together. So in Pick's disease, you may see these balloon neurons. You can see that they look very homogeneous. The nucleus is at the periphery. And you may see the Pick bodies, which are basophilic round structures. You can see one there and one there. You can also see these balloon achromatic neurons, just like in Pick's disease, but in a different condition. And then you may also get this grumose degeneration, which is basically a granular change. And you see this specifically in the dentate nucleus of the cerebellum. So let's talk about silver stains. Your Gallia stain is the most powerful non-immunohistochemistry tool to help distinguish between different tauopathy subtypes. So at the top, we have Bicholsky, and then we have Gallias at the bottom. So if we look at A, we have some neurofibrillary tangles. Sorry, I'm going back to Alzheimer's disease, but you can see the flame-shaped morphology. Here we have some granuloculair degeneration, like in Alzheimer's disease. Here we have some neuritic plaques surrounding an amyloid core. And then when we go to this one here, F. So I hope you remember, and you can tell me that this is Pick's disease because they're really, really round. And then I'm going to show you this G and H just to prove a point that Gallias is much better. So in G, you can see this is a corticobasal degeneration. So we are looking at this, and you can see how much clearer that is on this H stain. Here you can also see this kind of comma-shaped inclusions that, as I told you earlier, are a clue that this is corticobasal degeneration because they have a comma or coil-shaped argyrophilic, and it looks way better, much clearer than in Bicholsky. And I'm going to ignore these ones because this is a different condition that I'm not talking about today. So PSP is a 4R tauopathy. You will see this hummingbird sign. You will see neurofibrillary tangles and the tufted astrocytes. That's what you need to remember. And this is what they would look, again, macroscopically. So you would have the globus pallidus is going to be discolored. Not the best image to show you that. But you will have a reduction in the height of the midbrain tegmentum and tectum. The substantia nigra will be pale. And then you're going to have blurring of the dentate nucleus. And here is the MRI image I promised. So you have this hummingbird sign. It's also called a penguin, but I'm from South America and we have hummingbirds. So this is what it reminds me of. You will see neuronal loss, gliosis, and neurofibrillary tangles. And without immunohistochemistry, if you have midbrain degeneration, so this is really, really, really thinned, you can see that the subthalamic nucleus is involved, and you can see globose tangles, and you can definitely say that that is what it is. If you have immunohistochemistry, fantastic, because you can see the tufted astrocytes. If not, then you can use the gallias to look at the morphology. CBD, again, a 4R tauopathy. And important, again, balloon neurons. You will see neuronal loss and astrogliosis in the substantia nigra, and you may see thread-like inclusions. Again, we're going to look at gallias. So this is an example. We have discoloration of the globus pallidus, is this little triangle here. You can see the different color between that and that. The pontine tegmentum is going to be reduced in height, and the superior cerebellar peduncle is going to be atrophic, as you can see there. The dentate is also going to be blurred. So you can see why CBD and PSP look kind of similar macroscopically in a way.